All right. Hello, everyone. Just give me a second here. I'm going to share this over on the original Big Discussions 76 channel. I'm also waiting on the Scientist Supreme. She's out on the West Coast, and she is my featured guest. So let me make an announcement over on my original channel. There she is. She's there in the chat. Whenever you want to, Nikole, I'm going to give a few opening words. I'm not going to be too wordy. I'm not going to be too long, but whenever you want to come in the backstage, I'll bring you right up. So let me share this. I hope everybody's having a good Friday today. I'm glad it's Friday. Let's see. Discussion. Nikole on prostate cancer. So that's been shared. All right, let me go over to my actual channel, and then we'll get this party started. All right. So guys, as you can see, I'm doing this the old school way. I'm going with the avatar. I'm having a special shave tomorrow, so the beard is looking kind of not appropriate for camera. I'm not camera ready, so I'm doing this the old school way. Yeah, give me 1 second. I did send it a couple days ago. I'm gonna send it to our dialogue last night. Okay. Okay, I just sent it to you. All right, everyone. I'm going to jump in here, and we'll get this started because this is a lunchtime stream. All right, everyone. Welcome back to my channel. My name is Dr. Anwar Yusuf Dunbar, and this is Big Discussions 76, Science and Technology. First of all, please like this stream or video. If you're watching this on the playback, please share it. And please subscribe to my channel. A few quick housekeeping items here for marketing purposes and those kinds of things. Let's see. There is a Big Words blog site. That's the URL for my blog, my first blog. I have a Facebook page there, and I have an email address there specifically for my YouTube content. That's my Twitter handle right there. And that's my Instagram handle right there as well. I don't have a super chat on this channel yet. I thought that once I passed 1,000 subs, that would automatically kick in. The community tab did, but if you know anything about YouTube and if you're a content creator, you know that you have to have the 1,000 subs, but you also have to have 4,000 hours of viewership. So I don't have that 4,000 hours of viewership yet. So what I'm going to do, if anyone wants to make a donation during this stream, I'm going to drop my Cash App and PayPal in the chat. Periodically, depending upon how many people we have coming through. And this is below the playback as well, if you're watching this on the playback. So Microsoft Word is opening up right now. I'm happy that Nikole is coming back today. It's always a pleasure when she comes. And I plan to have a few more guests come in other parts of the STEMs. Me and Nikole, as we'll describe, if you're unfamiliar with us, we both have backgrounds in the biomedical sciences, but the STEMs are broad. And I want to turn this channel into a bit of a STEM hub, which means I want some of the tech guys and the tech gals or the tech folks to come over as well. I just had Brother X come and talk to us about mechanical engineering a couple of weeks ago. And I also had Dr. Werner Morris come and talk to us about the atmospheric sciences as well. So there's much more to come on this channel. Okay, so I've seen the Scientist Supreme is backstage. So I'm going to just go pretty quickly here. Guys, we're going to talk about prostate cancer today. There was something that Nikole said on, I think, one of BGS's panels a month or so ago that really, really intrigued me. And I'm going to tell you why. But we're going to talk about prostate cancer. And so I'm just going to give a very, very brief intro to cancer. I mean, this is a whole field, and there are whole textbooks on this. There are videos on this you could probably watch here on YouTube. And it's a disease that's been with us for a while. Conspiracy theorists would probably tell you that Big Pharma already has a cure for this, but it's not in their best financial interests to release a cure. It's more profitable to just keep treating it. I'm sure we've heard those conspiracy theories, and I better not say too much about that because I don't know if that will upset the YouTube folks. But cancer, just briefly. Let's see, cancer. So Nikole, it looks like you have a blank image, a black image. If that's what you're shooting for, that's fine. I'm used to seeing your image. Let's see, cancer at a high level. You're thinking about the uncontrolled division of cells. So we know that our bodies consist of organs and systems, and if you go even lower than that in terms of complexity, those tissues are made up of cells. And so what happens in cancer is that you get an uncontrolled division of those cells, and this can happen in numerous tissue types. Okay, Nikole will be right back. So that's what cancer is. I'm sure and all of us know someone who has had this condition, and hopefully you never catch it. Hopefully I never catch it. Hopefully none of us ever catch it, or hopefully it never develops within us. What are some of the causes of cancer? Well, if you're in the biomedical sciences, you know that there are several causes. Some of it, there's your picture. Some of it, one potential cause is the environment. I'm thinking about radiation. This is a diagram of the electromagnetic spectrum. Regardless of what science you go into, you will have a physics class, you will have a chemistry class, and you will learn something about the electromagnetic spectrum. I did show this figure in some of the earlier 5G videos I made. But just briefly, for the sake of this discussion, if you look at this spectrum, you can see the wavelengths changing at the top, and you can see the nanometers for those constituents of the spectrum changing. And I believe once you get into the ultraviolet range and up, you can cause DNA damage, and DNA damage can lead to undesired effects such as uncontrolled cell division. So environmental stimuli can cause cancer. In my field, I'm my backgrounds are in pharmacology and toxicology. We know that exogenous chemicals can cause cancer. Some chemicals can cause DNA strand breaks, and we know that those can lead to abnormal proteins and uncontrolled cell division. In my field, and I'm going to be very cryptic about this, in my field, we know that certain chemicals can disrupt hormone homeostasis in certain tissue types, certain organs. So if you disrupt hormones, if you get too much of a certain hormone floating around, if you get disruption of a negative feedback loop, you can cause a tumor by stimulating a receptor on a specific tissue too much. So chemicals can perturb hormonal pathways. And we also know, and there are probably other examples of things that can cause tumorigenesis. I'm sure Nikole knows quite a few, but also we know that aging, we know that certain tumor types occur just through aging. This is a diagram of an animal cell that I've shown in many of my videos. And as you're watching, if you're looking at this, I want you to keep in mind that there are quite a few closely or tightly regulated pathways within our cells that are not depicted in this diagram. And as we age, sometimes those pathways become less tightly regulated, and that can lead to uncontrolled cell division. In my 9 to 5, we review cancer data where animals are exposed to a specific chemical classes. And sometimes when you look at those animals, sometimes tumors just randomly form as the animals age. And we have to decide whether or not those are treatment related or not treatment related. So I'm saying this to say that sometimes with age, you can get tumors formed. And how does that happen? How can that happen? This is another figure that I've shown recently in one of my videos where I've talked about, the Western blot analyses and protein structures and protein folding. Sometimes one theory is that when pathways break down, you get a certain amount of misfolding of proteins, leading to something called aggregation, and that can lead to cancer. So I'm just saying this to say that there are numerous ways in which cancer can occur. And I'm going to tell the story, and then I'm going to bring Nikole up. A couple of years ago, since we're talking about prostate cancer, my father had a prostate cancer scare, and the lab data showed that he had an elevated PSA score, or an elevated PSA level. And I'm sure Nikole will tell us more about that when she comes up, but that's basically, and she can correct me, a biomarker for prostate cancer. So my dad went through this scare, and we all went through this scare together because he, I'm sure if I had an elevated PSA level, I'd be afraid as well. But I was intrigued a couple of months ago when I heard Nikole say that that's not an accurate biomarker, or that's not an accurate indicator of prostate cancer. And that's what I wanted to ask her about. So I'm going to ask her, I just gave her a very, very brief overview of what cancer is, but one of the questions I'm going to ask Nikole is, what are some other facts about prostate cancer? And then I'm going to ask her about why that particular test is not an accurate test. And then, depending upon how much time we have left, we may stray into some other areas. But with that, I'm going to happily welcome Nikole back to Big Discussions 76, Science and Technology. Nikole, welcome back. How are you doing?
I'm doing okay. How are you doing?
Good. Glad it's Friday.
Yes.
Forward to relaxing a little bit.
Yeah. Thank you for having me up here. I appreciate it. I have a lot of links and a lot of I had to put them, I guess, in the back chat. I'll try to put them in the live chat as well. But yeah, this is a good discussion, good topic. Just thank you for having me.
Okay. And family's good. I'll just be brief about that.
Yeah, yeah.
Okay.
She's it just so happened Jason had today off. He has in his job every other Friday off, and I forgot that today was that Friday. So I'm up at like 4 in the morning, you know, trying to force feed her.
Yeah, yeah.
And I was like, oh, in 3 more hours I'm gonna have to force feed you again. And so that you wouldn't have to hear her sucking her bottle on the mic. But he was like, oh, I'll take her. And they're in there watching Dante's Peak, no joke. So
Wow, that's a perfect movie for a baby.
yeah, yeah. She's actually watching it. So and laughing, trying to laugh and smiling and stuff. I'm like, that's not the point that you're supposed to smile, but okay. She thinks the volcano is funny. So
Wow.
yeah, we watch a lot of action movies, and she actually sits there and pays attention. She has a pretty long attention span.
Okay.
But yeah, so I mean, she's good. So I'll take her later on. But
Okay.
I was listening to what you were saying earlier, your introduction. Very good information you're giving. And I before you stated it, I was thinking aging, aging. I was like, that's number one. So people like myself, and even with pharmacology and toxicology, are, if you really break down the nuts and bolts of our fields, it's studying aging and how to combat that process. That's really what you're studying when you're thinking of developing different drugs,
Mm-hmm.
because certain drugs are essentially slowing down the aging process.
Okay.
Unfortunately, some drugs speed up that process. Um, certain illicit drugs such as methamphetamines, heroin, cocaine, they're actually speeding up the aging process in your cells, because the metabolism is much faster. Um, and you see that with a lot of the
Nicole, you still there?
supposed to slow down or at least ameliorate some of the symptoms of sickness. And sometimes that slows down the aging process, in a specific tissue. So either any way you look at it, you're going to be affecting aging or
Mm-hmm.
the telomere activity of the chromosomes. And you're going to be you can affect, like you said, with radiation, that is a therapy, um, at different parts of the spectrum that will induce aging because you're causing either single strand DNA breaks or double strand DNA breaks. And if those breaks, yeah, there you go.
My
If
favorite
those breaks
picture.
continue to happen, it makes it more difficult to repair the enzymes. Um, the enzymes such as ligase, for instance, that would be used as a natural glue to fix those nicks and cuts. If there are too many glue them back together, it's still trying to be made. And so you have issues with that. Aging, with aging, that happens a lot where the DNA damage can affect your immune system. The DNA damage can affect the way that you digest your food. And that's just due to us living a lot of the critical issues that we see now, chronic problems we see now: cancer, diabetes, stroke, cardiovascular disease. They lived until they were like, what, 40? If you were 40, you're elderly.
Hey, Nicole, you're going in and out just a little bit.
Okay, hold on. Let me try to. Let me try to move this. Okay.
Okay, so at this point, I'll just interject and say something really, really quickly.
Oh yeah, go ahead.
Because on my channel, I think it's important to kind of tie everything together. So when you think about, regardless of where you stand on climate change and the environment, the significance of the ozone layer is that it filters out specific parts of the electromagnetic spectrum, and so the theory is if certain parts start getting through, that can increase the incidence of cancer in the population.
Yes.
And also, if we think about astronomy and aerospace, well, we know that space is a vacuum and we can't breathe out there, but those suits are also designed to protect the astronauts from those parts of the electromagnetic spectrum that we're protected for on the surface of the Earth. And then one other thing, and I'll give it back to you, is that Nikole mentioned drugs, other industrial chemicals.
Oh yeah.
Yeah, can be cancer modulators.
Oh yeah, definitely.
I mean, and there are thousands upon thousands of chemicals that we're exposed to intentionally and unintentionally, and those things can cause carcinogenesis as well.
Yeah, they're steroid modulators. So they call them SERM, steroid, SERM. I forget exactly what the acronym is, like steroid something modulators or something like they're steroid receptor modulators basically. So for instance, you had just recently, this is like maybe 2 years ago, the pig farm across the street from a Black neighborhood where they were spraying the liquefied feces across the farmland to fertilize the farm. And you had this liquefied, no joke, liquefied feces spraying across. I think I did a video on it. It was in North Carolina, it was in a couple other states too, where you have hog feces being sprayed across the fields to fertilize the plants. Already that's questionable. But then it was getting into their filtration systems, their ventilation systems in their homes. And so it was hard to breathe. And they were saying this has been happening for years. It's just now gotten media attention. So that's an example of a potential SERM or a particular steroid modulator, because you have feces from an animal that's treated with different antibiotics, it's treated with different steroids and hormones already, and you're spraying that waste product, which includes bacteria and possibly viruses, into the air, and people are breathing that in. I mean, their cars were covered with it, their homes were covered with it, the trees, the grass, everything. We have something going on right now in Carson. There's a story about it in Carson. There's an open body of water, which is, I think, connected to the LA River. There's a smell like rotten eggs, sulfur, I think it's like hydrogen sulfide or something like that they're trying to find the source of it. Well, this has been happening for like almost a year now. And the people there have headaches. The children there have respiratory issues. The older people there have somewhat of a narcolepsy type of response to it where they just pass out. So yes, your environment is clearly, does affect you in many ways. Sometimes unintentionally, like you were saying with the ozone layer. And well, that's probably somewhat intentional as well, but depending on where you are, it probably wouldn't affect you as much if you have more trees, for instance, more oxygen produced and things like that. But a lot of it I see is, intentional. You see that intentional, and that's just biological warfare, in my opinion, because you have people who are afraid to say, hey, something's wrong, and then afraid to figure out the source of it. Well, they know the source. They're not going to change it because it's not financially feasible for them to do that right now. And so what they're dealing with in Carson, it's probably going to be a big cleanup. We already have the oil spill. Obviously, there's organic matter. There's animals, birds there that are affected by another oil spill. And these are two separate issues in LA right now. Like right now, an oil spill in the port of Long Beach, and the smell that in the standing water in Carson. So those are two examples of environmental issues going on that could affect steroid hormones, could affect steroid receptors, because we don't know, like you just said, so many chemicals. Many of the chemicals affect the gonadotropin receptors, affect the gonads, affect steroids, affect the pituitary gland, and different hormones that regulate the pituitary gland. But number one, above all of the reproductive issues that you could have, number one would be the thyroid that would be affected.
Yep.
And so that is very critical, because I know, like on a news broadcast, they said they wanted to check people's thyroxine and their thyroxine levels from their thyroid, and see if they needed any help with regulating that. And I'm like, that's more money. Why don't you just, this simple question, hey, why don't you just drain the water and get rid of the smell? I mean, it's yeah, it's crazy.
Okay.
But yeah, that's an example of the chemical component in your environment that can affect you in many different ways. So
okay, well, I'm going to add one more thing. I'm going to ask you to break down what CERN is one more time. But another chemical class, since you mentioned hogs, livestock, they're ingesting pesticides as well.
Yeah.
So, and they're metabolizing those pesticides, and so you can add that into whatever it was they were spraying around. Yeah.
So a SERM, I just looked it up. It's a selective estrogen receptor modulator. So men think that, oh, it doesn't affect me. Yes, it affects you, okay, because you have somebody around you has estrogen receptors, and hello, you do have estrogen receptors as well. And if you're all hormones start from cholesterol.
Yep.
If you're a man over a certain age, your testosterone drops. Well, if your testosterone drops, the obvious seesaw effect of that is estrogen usually goes up. Okay, so if you're an older man, you definitely have to be concerned with SERMs. For the most part, people say that SERMs are only drugs. They're only in certain types of medications. Well, if you're giving, like with the pig example I gave, like you just said, pesticides are considered medication to prevent pests from eating your plants. That's a medication. The different drugs they get, all the different lists of drugs they give the hogs on a pig farm, those are medications. And you see how if you're spraying that liquefied fecal matter in the air, you're being exposed to those medications, those potential SERMs from those pigs in a way that you should never be exposed to. That's a biohazard situation. And so the SERMs, people always say that they're just drugs. No, they're not just drugs that you take orally or intravenously. You can be exposed to them in other ways. If you smell something and your body innately knows this is not the right smell, it's more than likely something that could modulate your body in some kind of way, your thyroid hormones, your estrogen hormone, the testosterone in your body. Women do have testosterone, low levels, but we do have it. Regulate different tissues or affect different tissues that should not be affected by that particular chemical. So, I mean, I just want people to know, recognize, it is a problem.
So I'll share two more interesting factoids, then we'll jump in, because wow, we're already at 30 minutes. See, Nikole, this is so much fun when you come around. So everyone, so for those of you who don't know, organ systems, pathways, a lot of these are conserved across species. So, for example, Nikole mentioned the hog. Hogs have livers, just like us. So what your liver does is it metabolizes foreign compounds. So, and also plants have metabolizing enzymes as well. So these chemicals, they're going from species to species. They're being biotransformed. In some instances, to things that are benign, but in some instances, to things that can cause cancer or cause something else once they get inside your body. So that's the significance part of the significance of what we're talking about.
Yeah.
So Nikole, I'm going to show this picture here. We'll jump into prostate cancer, and please add on to what I say, or if I say something wrong, please correct me. But everyone, and Nikole, it's funny. I showed this picture, I think, in our first collab, and I never really took a look at it. I just kind of said, "Oh, there's a prostate cancer picture."
I think your audio went out a little bit.
Okay, I used this picture in our first collab, and I didn't really look at what was happening. I just said, "Oh, this is a cool prostate cancer picture." But what happens is, that's your bladder for gentlemen. Of course, women have a bladder too. But that's the urethra. That's the passage through which the urine goes after it collects from your kidney. And the prostate gland, it appears to fit around that urethra. And correct me if I'm wrong, Nikole, that's how a man controls, at least in part, the flow from the bladder to, wherever it goes. And so that if a man develops prostate cancer, there's the formation of a tumor in the gland, and that can basically pinch that urethra shut so that the urine has a hard time leaving the bladder, if at all.
Yeah. The first thing that happens is usually you have some type of DNA damage that occurs. So with the cells, and I can share in a minute, but with the cells, you usually have some type of DNA damage. You have changes in the telomerase activity, which is what controls the aging of the cells and everything, and the aging of these particular genes on the chromosome. So when that happens, you have a lesion that forms, a small lesion, like I guess you could say it's like a cyst that will form for the prostate, and that begins to push against the you'll have that form into what is called like a BPH, benign prostatic hyperplasia. Hyperplasia is a plastic lesion, a lesion that can grow in size, change in shape, and that's really all it is. Hyperplasia is the plasia part is like plastic or a sore or a benign tumor, and the hyper is it's very active. That's really all it means. A hyper sore, a sore that changes shape, changes form, can split. So you can have two tumors. You can have a tumor that's wrapped around the urethra, one that's compressing the urethra like you have in your picture. And then you have from that, usually those symptoms, they are like difficulty to urinate, difficulty with ejaculation, pain in that area, very sensitive in that area. And usually men can feel this in their rectum as well. They can feel in their hips. And it's just a slow growing pain that occurs because prostate cancer is a slow growing cancer. It's not like some other cancers that people study and that patients have to deal with. And then you get to a point where so this would be the best point when you have hyperplasia, BPH. That would be the best point to do a PSA test. The problem is a lot of patients are older because usually that's around 40, 50, 60 years old. The problem is a lot of patients are 70, 80, 90 years old, and they want to get a PSA test. And we don't have any data from when they were 50, 60, 70 to tell us how the PSA has changed based on their everyday experiences and other drug interactions, because they're taking other drugs for other things, right? So we don't have any data on them, and they want to come and get a PSA test. You can get a PSA test, but you really can't really be surprised as much as a physician or as a scientist when you see this person 80 years old and their PSA is 25, when the normal cutoff is at 4. You're at 25, and it's like, well, you're older, you have a malignancy, you ignored the pain and the inability to ejaculate and urinate. What was going on? Where were you? What was going on with you? So that's a lot of things we ask, like, what was happening. We try to educate the patients to go in earlier. As soon as you start feeling that pain, anywhere down there is, that's a very important area, I would think, for men, right? You need to go check that out. Because and a lot of men think, oh, they're gonna cut things off of me, and not necessarily. There are other adjuvant therapies that are used. Radiation can be used. Surgery can be used. There's different types of surgery that can be used. But if you ignore it, or if you get the PSA and it's 25 nanograms per mil, for instance, and the doctor suggests you do certain things, and you say, oh, forget that, doctor, I don't care, and you ignore it, then you get into a point where the tumor can reach a critical mass where it just grows out of control. And where this picture you have on the right, where you have this prostate tumor compressing the urethra, just expands to the point where pieces of the tumor begin to get edges of the tumor are not round like that. They start to get jagged, and those cells break away and go elsewhere through your body. The first place they will go is to the bone marrow. The next place they will go is to the liver. And the third place they can go is to the brain. So most patients with that metastatic form of prostate cancer, which can happen, does happen a lot. I would say about maybe a fourth of the patients have some form of metastatic prostate cancer. The ones that have advanced prostate cancer, they have either ignored treatment or they have failed treatment. And a lot of patients fail treatment because they come in too late for treatment. So that's the thing. They come in too late for a PSA test. And they come in too late for any type of, not even a PSA test, because when you're dealing with the prostate, you're dealing with a very specific part of the body for a man. Yes. They don't even, like, a lot of patients don't even want to come in for a standard physical once a year. You see, like, when's the last time you had a physical? 8 years. What? Like, okay. And we have to, as a scientist, because I'm looking at the slides and stuff, and I'm looking at the doctor's notes and everything, and the doctor's like, what, 8 years? They're like, okay, well, we have to start from somewhere. We have to start where you are and start treating you where you are. And if you're in a bad place, that's when a lot of patients are like, oh, I don't want to do this, I don't want to do that, and it's troubling, because a lot of the patients that I see with these bad prognosis are Black patients, because I notice a lot of the Black men that have prostate cancer, it's advanced prostate cancer. It is very bad. And this goes back to our previous earlier discussion about certain chemicals and certain equipment and machines and equipment that had to be lubricated, certain equipment that was painted or had some type of chemical, some kind of chemical exposure. They weren't wearing masks or respirators and things like that. So that, I think, in some ways contributed to a lot of older men we see now who have prostate cancer or some type of reproductive issues. Many of the patients have been in the military, they're veterans, and they were exposed to who knows what in different countries and elsewhere. Even in the United States, they probably have been exposed to things. So all of that goes into it as well. And I have, let's see, I'm gonna try to share this. Let's see. Share screen. Window. Okay, here it is. Okay, I want to share this window.
Okay.
Because I have a few things on here. Well, I have a lot of tabs. Not a few. I have a lot.
Okay. Yeah. Whatever you want to share, feel free to go ahead and do it.
Can you see my screen on there?
Yes.
To share it?
Yes.
Okay. So if you go to, I'll make it simple. If you go to pcf.org, it's prostatecancerfoundation.org. You can find out everything you need to know. And even myself, I go on here every once in a while to update myself on 2 sections, the about prostate cancer section and the science and impact section. These are my 2 go-to sections. News, not too much, but if you want to do that, that's fine. I suggest you go to all the tabs and look at anything on here. But if you click on the about prostate tab, all of these tabs come up, all these links come up for anything that you want to know about prostate cancer. I mean, everything is pretty much, when I went through last night, I was like, okay, everything's pretty much here. Like that we talk about at our conferences and whatnot is pretty much all here. So they have like what is prostate cancer section, diagnosis and staging, prostate cancer treatment, and then lastly, side effects. Sometimes side effects is the most important section for patients and their families, to look through. So you can go to the prostate PSA test, the prostate specific antigen test, and there's also the prostate specific membrane antigen, or PSMA. So there's PSA and then there's PSMA as well. I don't know. I keep getting this. Okay. That keeps popping up. My lab chat. I'm gonna unpin that. So they have a video here. What is a PSA test? And they go through all of that. And what does it mean and everything. So a PSA test is what a PSA is not the digital rectal exam. Those are 2 different things. I want to make that clear. A PSA test is a blood test. They take blood and they determine from the blood how much PSA or how much of that antigen, how much of that protein is there in your bloodstream. 4 nanograms per mil is the minimum. So usually it's like 4 nanograms per mil to 10 nanograms per mil are considered, okay. You're in an okay range. Anything above 10 is a problem. So down here, back in the day, a PSA of 3 or 4 was considered normal. Now they had to increase that because they know already that things like age and race are contributing factors to having higher PSA, even when you have no cancer detected. And Black men historically have been known to have higher levels of PSA than other men that were tested. So that's why there's a range now. And I have here, this is from the American Cancer Society. It's a different link, a different window, but they talk about PSA in the blood here.
Okay.
So it is measured in nanograms per mil or per milliliter. And that cutoff is 4 nanograms. So you can have 4 to 10. That's okay. When you get to like the teens, you're past borderline, and that's when your chances of having prostate cancer are much higher, because or your chances of having, even you can have benign prostate cancer. You understand? So when you get PSA, let's say your PSA is 15, they do a biopsy on you, and the biopsy shows heterogeneous cells, meaning that you have a mixture of different cells. Cancer, benign tumor, because the tumor cells can actually die out over time. They don't have to grow and grow and grow. Unfortunately, if you don't get any treatment right there, such as radiation or any type of oral therapy, anti androgen type of therapy, those tumor cells will continue to grow and they will push out all the normal cells. They will squeeze them out. meaning they will push them to the edge of the prostate where those normal cells don't have access to the bloodstream or oxygen.
Mm-hmm.
And they become hypoxic. Normal cells that are hypoxic, they die. Cancer cells that are hypoxic are fine. They're like, hey, I'm good. I'm okay. And they keep growing. They have no issues. So those are the things that we're seeing with on this particular, link right here. This is just showing like PSA, odor, like all the different reasons why your PSA will go up. Enlarged prostate, older age, prostatitis, which is just inflammation or infection, ejaculation. I mean, they have, it may seem silly, but they have riding a bicycle. I know. Certain urological procedures and medicines.
And Nikole, can I show? I want to show them something just so that they
Okay, let
know
me stop
what we're
sharing
talking
it.
about. So, in antigen, so that
Uh-huh.
means that they're detecting it. So that means that those cells, those cancer cells, they're giving off
Mhm.
a specific protein that's
Yes.
going into circulation, and they're using an antibody test
Yes.
to detect it.
Yes.
Okay.
Mm-hmm. Because the PSA is an antigen, so you need an antibody. Yes. So ELISA, you have an ELISA kit or ELISA plate that has the antibody, PSA antibody coated on the plate. Yeah, you can buy them now. But I mean, all the places you go to get your PSA test, they just have them already in the fridge or the freezer.
Mm-hmm.
But if you wanted to, I mean, if you wanted to make it, you can make them. It's not that hard to make an ELISA plate to coat it with PSA. You just buy PSA from Sigma. But when you go get your PSA done, like your father, for instance, that's how they did it. They took the blood, they spun it down, they took the plasma. They separate the plasma from the Buffy coat. They store the Buffy coat for other tests, and then they take they take the plasma and they dilute the plasma down to probably like 1 to 100, 1 to 500,
Mm-hmm.
1 to 50, things like that. And they have a standard, a PSA standard. They add that to the plate. They add the diluted samples to the plate in like triplicate or something.
Mm-hmm.
The antibodies on the plate. Then you wash off the excess that doesn't bind, and then you add another reagent to that plate, which will detect how much antigen is bound to antibody. Because whatever didn't bind, you wash that off.
Yes.
So now you have, this is ELISA. ELISA is like a old school method, but it still works. They still use it, and it's a colorimetric assay. So you let that stand for, and I'm giving a synopsis of the ELISA process, but you let that stand for like 30 minutes to an hour or whatever the manufacturer says. And then in the dark, room temperature or 4 degrees, whatever it is, then you read that on a plate at a certain wavelength. Go right back to your first picture, the wavelength picture. So maybe the wavelength that you're supposed to read it at, yeah, there you go, is like 490. So that's in the ultraviolet wavelength range. And usually it's like 490, or because you're looking at protein. When we do like what is it called, proliferation assays, it's like between the 4s and 6s, somewhere
Mm-hmm.
between there. So it very rarely is it like infrared. Usually the 4s to the 6s, which is okay. When you can see that range. And it'll give you the numbers. You have to take those numbers from the readout and calculate them based on your standard curve. So you need to put those numbers into the slope and intercept of the standard curve and see how many nanograms per mil you have, because your standard is going to be nanograms per mil, right?
Yes.
So if nanograms per mil is too small to physically pipette, then you have to do it micrograms per mil or milligrams per mil, and then calculate that to nanograms per mil. So nanogram is 1 times 10 to the negative 9 gram. It's a billionth of a gram. So if you can't physically pipette that amount in the plate, then you have to make it up for whatever you can physically pipette in the plate, and then calculate for nanogram.
Yeah.
And that'll tell you how many nanograms if you go for your test and they say, well, it won't be a range, it will be an actual number. It'll say your PSA level is 12.5 nanograms per mil. You're 45 years old. Why is your PSA this high? We need to do an x-ray. We need to do a biopsy. These are things we should probably do because you are 45 years old. You should not have PSA level of 12.5 nanograms. That's very high.
So, Nikole, well, scientifically, everyone, I think the other reason you want to dilute is so that you're in the linear range of your standard curve.
Yes.
But since you mentioned it, let's go back to the range. You said the range was 4 to 10.
Mm-hmm.
Would 2 units over that range, is that significant?
I don't know that I would say, I don't know. I would say yes if the patient has been coming and getting PSA tested for a while, because you can take all the different numbers and calculate the standard deviation to determine if that's statistically significant. If it's the first time, or if it has, if it's their first time coming in and they got 12.5, you don't know if that's statistically significant for that patient. Now, it probably isn't for the range 10 versus 12.5, but I would still, as a physician, as a person who's doing this analysis, I wouldn't ignore that 12.5, because 12.5 can easily become 15 within a couple months.
Yeah.
I would not ignore that, and you notice I didn't mention digital rectal exam. You don't necessarily have to do that. There are ways around digital rectal exam. You can do biopsies. You can do, x-ray will give you a good idea. Biopsy is probably the best though. And then you have people who've been coming in and you see a slow increase of their PSA. Maybe 12.5 for them is significant, but for a person where this is their first time, it is not. So it's hard to say.
Okay.
I'm putting the link in here in the back chat while we're talking.
Okay. I'm going to go back to, I'm going to copy this. I'm going to go back to a couple of things you said just to verify for the audience. So one issue you said is that a lot of men don't go and get their levels looked at until they're in their late 60s, early 70s.
Mm-hmm.
Okay. That's around the time my father got
My dad, yeah.
Mm-hmm. And so if I heard you correctly, the issue with that is you don't know what the number was back at 50.
Right.
So it could have very well been that number 20 years ago, but you don't have a prior point, so you don't know.
We don't know. Yeah. And someone was asking in the chat, Kalila, she said, at what age should men get the PSA done? I would say get it done like 35.
Wow.
35, 40, because we have people who have men who are like, late 30s that have prostate cancer or have BPH. Like, you should not be in your late 30s with BPH. But there are men who have BPH late 30s, early 40s and stuff. And it's not good because it does affect your reproduction rate. Clearly, it's going to affect how you are able to have a standard of regular life. You don't want to be debilitated in your mid to late 40s as a man. Plus, you have to think of the costs, the healthcare costs. If you don't already have full coverage, healthcare insurance, then how are you going to pay for this? Even if, people don't think about these things because they're in their 20s and 30s. They're like, yeah, living it up. But yeah, you might have some problems going on. You might have a silent killer that you're not focusing on. I would say definitely, like, if you're not going to do it in your late 30s, or at least talk to your doctor and try to get tests done. It's not that hard to go ask your physician, hey, can I get a PSA test done on me? They might look at you like you're crazy, Doesn't matter. Do it anyway. Say, hey, I need to get this PSA test done, a plasma screening done for PSA early. The problem, that's why I was saying that other time, the problem with PSA is men go in so late. Like you just said, like we looking at them like, dog, I don't know what to tell you. Like you're like in the 20s. Your PSA is in the 20s. I mean, I've seen PSA in the 40s and 50s.
Wow.
But unfortunately, the patient I was doing the analysis for the plasma on, they passed 2 years ago. They passed 2 years before I started doing analysis. I just need to do analysis for the plasma for another marker. And I just happened to have tons of plasma sitting around the freezer. But a lot of patients that were in that box, it said, date of expiration, which is when they died, date of expiration for the subject was, I was like, that's 2 years ago. This is 6 months ago, so unfortunately those are the last readings from them, 40s and 50s, nanogram. That should never happen, but it does happen with some patients. And out, some of the cells can always grow back. If they don't take all of the tumor out, there's always a chance that some tumors will come back, that cells can grow back quickly, which is why, because prostate cancer is slow growing. I'm gonna keep saying that prostate cancer is a slow growing cancer. Early detection is very important. It's not like colon cancer or ovarian cancer or cervical cancer that grow very fast. It grows very slowly, but if you ignore these tests and preventive strategies, it can be devastating.
Okay. I'm gonna
I have the links too for Kalila. I see she has questions in there.
Okay. This question is from his name is my name too. He says, is this something I can ask my primary doctor to refer for a screening?
You have to refer, yeah. Primary doctors, like a general prac, they probably not going to do it. You have to be referred to a urologist or oncologist.
Well, I'll add on to that depending upon the primary doctor you have, this might be an afterthought for them. I was thinking when you were talking to Nicole, I can't think of my current primary doctor saying, hey, you need to go check for this. So sometimes they're not even. Sometimes you need to ask the question yourself, unfortunately.
Yes. That's what I've been telling people for a while about it. I was like, you have to ask them yourself. And then they ask, well, why do you need this? Like, okay, first of all, when you're in the doctor's office, you're paying them indirectly or directly. Okay. Indirectly through your insurance, directly out of pocket. And they wouldn't have any business. They would be sitting at home twiddling their thumbs or something, or teaching at a medical university somewhere if it wasn't for the patients that come in there. So don't let them rush you out the room. Number one, I always tell people that. Do not let them rush you out the room, because you are paying for their service there. You are paying them by the minute or hour, whatever. You paying them to be there, to be there and help you any way possible. If they don't know the answer, you need to get somebody who does know the answer. And like you just said, that is a perfect way to state that. Is a lot of times it's like an afterthought to them. It's like they don't care. You have to make them aware. Yes, I know what this is. I need this test to just see, what's going on. Well, I can't give you that test. You're like, okay, well, I'm going to go to another physician that can give me that test. So can you refer me to someone, a specialist that can give me that test? Then you find out, is that test covered by my insurance? A lot of times these things are covered by insurance. They don't tell us that, outright. Yeah. Same with breast cancer and cervical cancer. They don't tell us that as Black women. They don't tell us that because white women are number one women that still get breast cancer, but Black women are number one women that die from breast cancer. And so it's like imperative for Black women to ask about these tests for breast cancer, and for Black men to ask about these tests for prostate cancer. And not just prostate and breast, there's other things too, because you have there's a whole world of resources that open up. I had on that PCF link. When you start getting your PSA check, then they start giving you other things, nutrition, things for nutrition. Like there's so many different government programs and grants that have been awarded to determine if nutrition really has an effect on prostate cancer patients. Yes, it does. You know, are you drinking enough water? Are you getting enough sleep? Are you getting enough exercise? You know, are you getting restorative sleep, or are you just, you know, are you just going to sleep and waking back up again? You know, insomnia. Are you dealing with insomnia? So all of those things, people can help you with. They just don't tell you that outright. But yeah, a lot of those things are covered by your insurance, and they can help you with it. You just have to ask. My dad doesn't even ask. He just tells them what they're gonna do, and they do. They do it. Well, he just says, "You're gonna give me this. You're gonna give me that," and they like, okay, his insurance covers it all, so he's good.
Well, speaking of which, and Khalil is asking this. I think you mentioned some of these earlier. We can go back over those after I finish. But my recent visit to my doctor, my shoulder had been bothering me. It's feeling better now, but I was thinking, I want to get an X-ray so I can see what's happening in there. He was like, "Oh, I'll give you a cortisone shot," and I was like, "Dude, I don't want a cortisone shot. That's just going to mask the pain." And there are complications with cortisone shots. I said, "No, I want to go see a specialist. I want to get some X-rays taken." So I had to insist, but otherwise he'd have been happy just giving me the cortisone shot.
Mm-hmm. Yeah, because that's a revolving door. You keep coming back for the cortisone shots. And my mother had similar issues, skeletal issues with her, I think it was her knee. And they were giving her a cortisone shot like twice. The second one, she was like, "No, I need surgery. Like, I need surgery." So she had to switch doctors.
Yes.
And the doctor was like, "What were they doing? Why did they keep giving you cortisone shots?" She was like, "I don't know, but I've had the second one. I don't like the side effects of it." And where she felt like she couldn't use her leg after the shot. And like from the knee down, her leg was just numb. Like she couldn't use it. She was like, "What is going on here?" So they said, "Well, how many shots have you had?" She's like, "This is the second shot. The first shot was fine. No, it don't numb the pain, and it was very dull, no pain, nothing. The second time, it's causing paralysis, temporary paralysis." And so she said, "No, this is not for me. I'm not trying to have my whole leg paralyzed from a shot. It's like that. It's like a cartoon type of situation. They're trying to tell you, well, there's no pain, but you can't use your leg. Okay, like your leg is paralyzed. Well, there's no pain though. Like, really?" So she said, "This is crazy." And she got surgery. It was a very simple surgery. It was like 3-hour surgery. She went in, inpatient surgery. She was actually awake when they did the surgery because they have to know if there's any kind of discomfort when they're doing it. And so she did that. They gave her local anesthetic and everything, wrapped her up. My brother took her home. Within a week, she was fine, and she hasn't had any pain since then. So yeah, she's fine. I mean, this was earlier this year, like back in March. So she's fine. I mean, that instead of taking, now the surgery was maybe the cost of 5 shots. But if she had continued taking the shots, she'd probably still going up. Doesn't make any sense. So I agree with you on that. My mom dealt with that. And you're just like, "Hey, just let me get an X-ray and see what's going on." I don't blame you. I would have been asked for X-ray, MRI as well, because if it's in your shoulder, that's too close for me. Anything above the waist is like, it's too close to my heart. I don't like it. Anything above the waist, it's too close to my heart. I don't like it.
So, folks, the take-home message is doctors make mistakes, and it's okay to ask for more than what they're initially offering, and sometimes you have to be insistent and maybe get a second opinion from another doctor. I'm going to make an announcement. Kalila, we're going to come back to this. If
Oh,
anyone
okay.
wants to donate to the channel, I'm going to drop my Cash App and PayPal. Nikole, thank you for your donation at the beginning. That's there. I'm going to answer Snuggles' question because there are people who are coming in who. Hold on, that's the wrong. Because there are people who are coming in who don't know what cancer is, so I'm just going to briefly show that picture again. 1 second. If you want to make a donation, my Cash App and PayPal are here. And the fact that some people don't know what cancer is, it's valuable that we're doing this.
Yeah.
So we're going to come back to that, Kalila, in just a second. Folks, cancer is it's uncontrolled cell division. And depending upon the tissue type that it's in, it can be lethal. So especially if it becomes malignant and it metastasizes, because it can spread to other parts of your body. But even if it stays in that one area, me and Nikole are talking about prostate cancer, it can exert harmful effects if it just stays in that one area. In this instance, we're looking at the urinary tract of men, which I have another question about that, Nikole. You have your prostate gland there. You get urine from your kidney, your glomerulus, or you guys glomerulus. The urine collects in the bladder, and then best case scenario is it filters out in your urine through the urine filters out through your urethra.
Yeah.
If you get a tumor formed in your prostate gland, that's gonna basically decrease the diameter of that urethra, so your urine can't empty out, or it's going to empty out in a very inefficient way.
Yeah.
So that's what we're talking about, Snuggles.
And it becomes very dangerous because if you have this backup of urine, I mean, ideally urine is, it is sterile. It is a waste product. It's, there's urea there. There are things there. The bladder is not made to hold urine for an extended period of time. And of course, over time, urine becomes oxidized, and you have all this urine that's collecting in the bladder. It begins to back up. This is where a lot of patients with advanced prostate cancer, they have to have some type of they have to take medication for that. They also have to have like the bag, the external bag that is coming directly out of the bladder to help drain out the excess urine, because it will actually affect your kidneys over time if you have this urine that's backing up into your system.
Yeah,
it's a one-way system. It's no two-way thing. You can't go back. And so they need to get that urine out. Also, it's very critical to get that urine out, because those patients are taking high amounts of medication, and sometimes they're on chemotherapy or they're on radiation therapy where you have to urinate. You must get the excess chemical or radiation out of your system, immediately.
Yes. So, Kalila, Nikole shared this link here. I believe the answers to your question.
Yeah, it's there. It's a whole list of different symptoms. I was just looking through myself, and they have, oh my God, like if she clicks on the link, she'll see there's a video about it, and then under that video they talk about different symptoms that it says in rare cases. That I don't agree with that, but it says on here, in rare cases, prostate cancer can cause symptoms. For the most part, I would say men have these symptoms that they're mentioning at the bottom because they're at a later stage. So this, I don't know why they're saying in rare cases, but these are very common when you have a need to urinate frequently, especially at night, sometimes urgently where you don't even make it to the bathroom. And then other times where you have urgency to urinate and nothing comes out, which is scary. In my opinion, if that happened to me, I'm going to the ER right then. Like you have this urge to pee, and then you go to the bathroom and nothing comes out. You're like, wait, what's all this? No, I'll be like, I put my contacts on. I'm getting my lip gloss. I'm getting my purse, my phone, I'm leaving. I'm going to the ER immediately. But a lot of men, they wait for years, and this is happening for years. Difficulty starting or holding the urine. They have weak dribbling or interrupted flow of urine. Pain and burning. Hello? Pain and burning. Hmm. I mean, you're not worried about if you have something else going on, like a lot of men don't want to deal with the doctor, and I get it. But you always can get a second, third, fourth, fifth opinion. There are a lot of other things they have listed here. If you have blood in the urine or semen, pressure or pain in the area, pain or stiffness in the lower back, hips, pelvis, or thighs. Come on now. You gotta get that. You gotta get that checked. You're welcome, Kalila. That was a good question that you asked, because a lot of people don't know the symptoms. Everybody has an uncle or older man in their family, somebody they know. I got this pain in my back. It's been going on for about 10 years, man. I don't know what it is. I had an uncle like that. He passed, and we didn't know he had prostate cancer. His wife, he told her not to tell anybody. But he had advanced prostate cancer, like a metastatic, castrate-resistant prostate cancer, because she had all these. I saw the medications. It was a tub of medications. Those big plastic, those big plastic tubs people use for storage in their garage and stuff.
Mm-hmm.
A Sterilite container. It was full of medications. I was like, what in the heck? And she said, these are all his medicines. I was like, oh my God. At that time, I knew what they were. It was just like anti-androgens, some kidney medication, heart medications, liver medications, medications to help him sleep, things like that. So I think the overall, like, it's very, very important. Get early detection. It's very important. And I don't think he did. I remember him always complaining about his back hurting. We didn't think much of it because he was in construction. But as an older person, you're not in construction anymore. You're retired.
Yeah.
Then we thought, well, he's just old. He's just an old complaining man. He's just an old man that complains all the time. No, he was seriously in pain. He was seriously dealing with a disease, chronic disease, and we didn't know. And I want men to feel like they can talk to their physicians. They can talk to people like you and myself about these things. Like, hey, it's not like we're gonna laugh at you or anything. I want to make sure that you're healthy. I want to make sure. I don't understand why a lot of men, like, maybe you can explain that to me, why a lot of men feel like I'm not going to the doctor. Nope, not doing it.
Well,
why
I
is
think,
that?
well, the saying says ignorance is bliss.
Oh.
You don't necessarily want to hear that something's wrong with you, and of course, preventative measures are better, as opposed to having to deal with them on the back end once the disease state has started. But probably just negligence and not wanting to know, trying to be strong, trying to appear strong. So I'm gonna see. We're at 1 hour 15 minutes. I'm gonna Snuggles asks something. I don't know how this relates to our current discussion, but Snuggles, this is vitamin D. This was you're probably asking because of the current world event, or Nikole, that's what I've been calling it, a world event. But one strategy was to increase your immune function, and vitamin D was one of the vitamins that was suggested for increasing immune function or strengthening your immune system. I believe this is also significant for bone strength. And I think we naturally produce some of this in our bodies, but Snuggles asked about what it is. So I just want to remind everyone, if you look at my library, all of these things go together. So if I make a video about transcription and translation, or something like domain architecture, or how proteins fold, all of this goes together with me and Nikole, with what we're talking about. So you may see me make videos about some of these concepts, but all these things go together.
Yeah. And so there's a vitamin D is very important. There's a doctor, well, there's a group at Northwestern, Comprehensive Cancer Center, Northwestern University. So they just did this came out in May of this year. And they were talking about how vitamin D deficiency, I just put the link in the back chat.
I just shared it.
Yeah, vitamin D deficiency is linked to aggressive prostate cancer. They did a study of Black men versus African American men versus European American men, a high risk of prostate cancer. They had greater odds of being diagnosed with an aggressive form of the disease if they had a vitamin D deficiency. So this has been studied by Dr. Kittles. I've talked about him before. Dr. Adam Murphy, and also Dr. Larissa Nahn. And she's like I have to look her up real quick, but that's all she does. She does work on vitamin D deficiency and vitamin D supplementation for prostate cancer patients. The issue with vitamin D, as you showed the chemical structure of vitamin D, is the higher amount of melanin you have in your skin, the less likely you are to be able to metabolize vitamin D, because you can't get vitamin D into your skin from, just being out in the people who are less melanated in the sun. They are able to metabolize vitamin D better than people who are darker.
Oh, interesting.
Melanin blocks that. You're blocking the rays of the sun, but you're blocking your ability to metabolize vitamin D through the skin. Therefore, you're blocking the ability for the liver to do the same, and the prostate and other organs that require vitamin D. So you get a lower amount of vitamin D. And what they were trying to see is if there are different types of vitamin D that can be used at higher concentrations, but not, they're called sublethal concentrations, or, not the highest concentration, which is bad, but something lower than that to help these patients with prostate cancer. And before doing any of those treatments, they found that the patients with the higher rates of prostate cancer, or like metastatic prostate cancer, they came in already having vitamin D deficiencies. So it just so happened that the Black men had worse deficiencies than the white men with prostate cancer. So they've already done a lot of study on that.
And that's because the melanin in our skin
blocks it. It's blocking, filtering out. Yeah.
The sunlight.
Yes. Okay. And she did it. I mean, she's done study where she looked at, because she said, the Black Americans are not a monolith when it comes to skin tone. So she did a study about skin tone, and the darker you are, and she's like, it had nothing to do with lighter skinned Black men versus darker skinned Black men. It had to do with certain single nucleotide polymorphisms that Black men have that white men don't have. And that also contributed to the issues with vitamin D deficiency.
Okay. So I'm going to go back just to recap, Nikole, and then there's one other question I want to ask you about something not related. I think we can close out with that. If you guys have any more questions in the audience, please ask those in the chat. So to go back, and correct me if I'm wrong, this PSA test, it's not unreliable per se. It's when the man goes to get it.
Yeah.
And how often he goes to get it. Yes. Okay.
It can be considered unreliable for another reason too. Also is if you jump around and go to different places where you're getting it done, that can cause an issue too. Getting it done because you're essentially supposed to get it done at the same place where they're using the same kit every time. Some people go, they want to get done here. Then they go, and then they get mad when one facility does it, and let's say the test comes out and says your PSA is 10 nanograms per mil. They go somewhere else, it says 8 nanograms per mil. They're like, oh my God, there's a difference. There's a difference. Okay, that's not that significant. But, that's not as significant as you think, especially if you just have BPH, and then if it were me, I'd be saying, okay, let me try to get a biopsy. It's a start. I think the PSA test is a start. where they can see like baseline, what do we need to do next? But you cannot use that as a baseline if the person is, in my opinion, if they're older than 60 years old, and if they have other health issues too, because PSA can be affected by other health issues.
Mm-hmm.
That's the other thing. It's a protein, it's acted on by different enzymes. And so there are changes in PSA. You can have the same patient come in, and they've done the study on that too, where patients came in like once a month, they test their PSA, it was going up and down the whole year. And these are patients that didn't have cancer, and it was fluctuating up and down, up and down. And they were asking them, okay, what did you do? What did you do this time? What did you do? Oh, I was taking different medications. Oh, I was in a car accident. Oh, I had this. Oh, I had that happen. So I was on this medication. Oh, I changed my diet. So that's why I'm saying it's not as good. The efficacy of the PSA test is not as good. Yeah, like you said, depending on when you get that test done. And I'm gonna share another link. This is from 2020 January. It's talking about vitamin D sufficiency enhances differentiation of patient-derived prostate epithelial organoids. So what they were trying to show is just vitamin D was good at higher levels in patients that potentially have prostate cancer. And this is from Dr. Nan. Like she's pretty good. I've heard her talks and seen her in person at these conferences, the prostate cancer conferences we go to. Dr. Kittles as well. He does really good work. He's in City of Hope out here. He does a lot of work with prostate cancer. Yeah, he actually runs, or I think he co-founded the, what is it called? The African American, with the DNA testing that they do. Yeah, I think he runs that. The DNA, if you have DNA testing done, he runs that. Him and it's another doctor. I forgot her name, but yeah, Dr. Kittles is pretty good. And these are physicians, scientists that focus on metabolites for prostate cancer patients. I don't know all the other things that vitamin D does. There's like basic stuff with vitamin D. I know that it's like it's a lipid-based vitamin, so you have to have like some lipids or in there in your diet or whatnot. Not tons, but you have to have some, because there are some fat soluble and then there's some water soluble vitamins. It's one of the fat soluble ones. That's pretty much all I know. I know that you have to have vitamin D for bones, the skeletal system. Vitamin D is also important with hormone regulation. And that's pretty much all my expertise on vitamin D.
Snuggles is still asking questions about it.
Yeah.
Okay, I'm going to drop this link in the chat. So a couple things you just said. So you said the number can bounce around. And
yeah.
That's what happened with my father. The number, it was up and it was down. And so we also said, if you get it done by multiple labs, if you have the test done, that can affect the number. Okay, so there's some variability in the number with who's executing the test, but also what the number of times you do it per year.
Yeah, number of times you do it like per year, you're gonna have fluctuations in that. As well, because you're going to have like, maybe when I say fluctuations based on like who is doing it and what kind of kit they're using, you might have a kit from company A and they only use that kit in this hospital, but another hospital or clinic, they use all the kits from companies B, C, and D. So maybe the standards are different. The source of the standard is different. Maybe the standard curve they use, the source of the standard does make a difference in certain things like that. The time of day they take your plasma, they take your blood, makes a difference, because as I stated earlier, when you have prostate cancer, you're going to have difficulty urinating mostly at night. If they take your urine at the beginning of the day, you could have a different reading than at the end of the day. So if you had difficulty urinating the night before, for instance, but you finally got it after 3 tries, you finally urinated, you're good. That next morning, your PSA level might be low. For whatever reason, it might be low. Later on, if you go the next time to get your PSA level checked and they have you come at 2 o'clock in the afternoon or 4 o'clock in the afternoon or something like that, maybe it's high then. So they are very specific about when they take your blood to do the plasma analysis of the PSA. You
Yeah.
usually have to come the same time every day. If you miss that appointment, they say we cannot take you. You have to come back like the next day.
Yeah.
So that's how they do it, and they have the same kit specifically done for those for the PSA tests.
So I'm going to show, I like pictures. I'm going to show 2 pictures here. Everyone, once again, this is an antibody test, number 1.
Yeah.
And also this, I just found this pretty picture of the prostate specific antigen right there.
Mm-hmm.
That's a 3-dimensional structure of it. But
Yeah.
guys and gals, what's important about what me and Nikole are talking about within the last minute is that in terms of the hormones in our body, they're not static. They're going up and down, especially depending upon the hormone. They're going up and down over 24 hours. So
Mm-hmm.
if you get the test done in the morning one day, and then if you get the test done at 4 o'clock on another day, you may see a different number. So if you're going for the test, if you know someone who's going for the test and you see fluctuations in the number, that's something to keep in mind. Also, Nikole mentioned that different labs are using different assays created by different manufacturers.
Yeah.
So there's variability in when the tests are done and also in the tools that are being used to
to analyze your
do things.
sample you have.
Yes.
Yeah. Because the analysis is the same. Math is math, numbers are numbers, but input is going to directly correlate with output, right?
Yes.
You input a sample from 8 a.m. It's not the same as input from a sample at 1 p.m. because you've eaten at least twice, right?
Yes.
So, your metabolites are different and things are fluctuating. All cells eat. When you eat, they eat. So that's how you have to think about it. It just, I make it like real simple because it's for me to explain it to patients. When they can understand it this way, it makes it easier when they have to, correspond with their physicians. I'm like, when you're eating, your cells are eating. They're not going to, I can't eat right now. I have PSA test coming up in an hour. No, they're going to eat when you eat food. When you don't eat and you're starving, they're starving. That affects the test too. So, they tell you not to change your diet and your lifestyle too much. If you're exercising and stuff like that, that's fine. You don't have to change your diet drastically and all this, but just be mindful that there's a reason why they're telling you come in at 10 a.m. to you get your blood drawn, and you go 10 a.m. on Monday, 10 a.m. on Friday, 10 a.m. the next Monday, 10 a.m. the next Friday. And then that following Monday, they might show you 4 different numbers. And they'll say, okay, here's where we are. They can't do it at different times. I wouldn't do that. When I collect my samples for analysis, I collect them. If I started the treatment 4 p.m. on Friday and it's going 72 hours, then 72 hours later at 4 p.m., I collect the samples. That's 72 hours, or if I'm going to add drugs after 24 hours, then I'd start this treatment at 2 p.m. on Thursday, then 2 p.m. on Friday. That's 24 hours. I need to add the next drug. That's how it's done. Otherwise, you don't know what's going on. You don't have any control of what's happening. Because it's just, when you do the analysis, it's just a snapshot of whatever's going on inside of your body at that time. And that's it.
So there are a lot of moving parts and nuances to running scientific assays and collecting data.
Mhm.
And for my father, the number, I think the number was like a 12 or something like that. And then a couple months later, it went back down to like a 4.
Mhm.
And I'd have to ask him if he had it done by the same lab or, but the point of it is that if you don't know that, he slid into a bit of a depression over this.
Right.
You
I
know,
can imagine.
and so as Nicole's describing, there are a number of variables that can account for the original number, why the number was up, why the number was down, and he went through a whole mental thing over something that might have actually been pretty simple. I want
Mhm.
to thank Ishmael for the Cash App. Everyone, my super chat is not live on this channel yet. So if you want to make a donation, I'll leave my Cash App and PayPal there as well. Nicole, I wanted to ask you: do women have some equivalent of the prostate? I'm a little fuzzy on my anatomy here, but is there, or is that they don't, or you don't?
Schematic you have on the slide. The prostate is supposed to be where the semen, or the sperm actually, develop, mature. You have semen there. So that's a holding place. Women don't have anything similar to this. The male reproductive system is extremely complicated compared to females.
Okay.
I mean, and that's not me speaking from a biased point of view,
Yeah.
but just looking at the male reproductive system, all the different nerves and vesicles. I mean, looking at the gross anatomy, it's like compared from a male mouse or male rat to a female rat. It's like, wow, this is way different. But there's no similarity, no comparison between male and female. You know this is a male, and you know this is a female, and you can tell outright when you see the prostate tumor. You know it's a tumor because the prostate is full of it's blood. There's a lot of blood there, and so the organ is red, very red. But anywhere there's a tumor, it's usually gray, tan, black, these different colors, which is they're indicating there's no oxygen there, or there's very little oxygen. Sometimes there are veins or vessels going in and out of the tumor itself because it has attached itself to the normal tissue, and now it's just sucking off blood, so to speak, like a vampire. In a way, it's just sucking off blood from the normal tissue,
Yes.
but it's not able to siphon off enough. So there are certain parts of the tumor that are hypoxic, and that is why it turns tan or gray or black. I've even seen like brown, where there's not that much oxygen there. But women don't have that because with women, the female reproductive system, you essentially have a vessel there that if it does get become cancerous, it shuts down a lot of other things for the female. And for instance, like uterine cancer, which can start from fibroids or endometriosis, that uh, uterine cancer, it can really grow very fast. Like within weeks, months, it can grow very fast. That's the main difference I noticed between female cancers and male cancers of anything below the waist is female cancers are very fast, male cancers are slow. Testicular cancer can be slow, prostate cancer very slow, but uterine cancer, cervical cancer, ovarian cancer, they're very quick. They're not like silent killers. A woman knows pretty fast like something's wrong, whereas for a man, it's not always the case with prostate cancer. That's why it's very important for early detection.
Okay. I'm gonna address this question by Snuggles. Snuggles is on a roll here, and then we're gonna kind of wrap up.
Okay.
Snuggles says, how does a chemical process or hormone precipitate change in the body? And I have a cartoon for you, Snuggles.
Oh,
This is a cartoon of a nuclear hormone receptor. This is just one way. So you have these receptors hanging out in the cytosol or the cytoplasm. A hormone indicated by that purple ball binds to the receptor. That receptor translocates into the nucleus, binds DNA, causes that DNA to it initiates transcription and translation. So a given protein or a set of proteins is produced. But the point is that you can have a hormone that's generated by the body start this process, or you can have a chemical from outside the body imitate that hormone, and start that cascade.
Or you can have a chemical that comes where they don't. There are certain chemicals. There are a few that I have in mind, but certain chemicals that don't affect the hormone, the little purple ball, until it attaches to the nuclear receptor.
Yes.
Because that dimerization, that's what is that heterodimerization of the hormone and the nuclear receptor. So that dimerization just means two things binding together. Heterodimerization is just two things that don't look alike binding together. That's all it is. And so when that dimer happens, there are certain drugs that will stop that from going into the nucleus. They'll stop that translocation. And there's other drugs that will stop that black arrow. You see what the black arrow is? That's actually a pretty complicated process. The black arrow that's going from right to left, going down. So you have certain nuclear ports. You have important proteins. You have chaperone proteins that scaffold around that nuclear receptor and hold it in place so it won't fall apart, and bring it into the nucleus through a channel. And the channel, every time as the nuclear receptor passes through that channel, it touches we call them little fingers. It touches the little fingers. And every time it touches those little fingers on the way in the door into the nucleus, it signals something else. So there are drugs that stop that process from getting into the nucleus. There are drugs that stop it from binding to that hormone response element. There are drugs that stop the mRNA production. And there are also drugs that stop protein production. So in other words, the hormone goes all the way through this step, and there's some drugs that stop the protein from being made. And the reason why those drugs are pretty good is because it tires the system out. One thing that genetically the system wants to do is conserve energy. It doesn't want to waste energy. Making mRNA is a lot of energy consumed to do that. Yes. And it's a lot of energy to consume, consumed to make the protein. But if you allow this process to happen and then the drug blocks the protein, if the cell is going to keep trying to make this protein, and it will tire out over time. It's like a transcription exhaustion, where it just becomes exhausted. And that's where you have a backup, where if you reverse this process, everything starts to back up and the system falls apart, the cell dies. So there are drugs that do that just block the protein production, the protein that's produced. Enzalutamide is a drug we use. It blocks the hormone response element, the androgen receptor, for prostate cancer. So it will block the binding and transactivation of androgen receptor. And then you have things like abiraterone that block the hormone from binding to the nuclear receptor. In breast cancer, you have tamoxifen. Tamoxifen or hydroxytamoxifen will block the nuclear receptor from binding to the estrogen. So you stop everything above the nucleus in that case, which is good because then, you can stop the production of the proteins altogether. So that's a good diagram. Very, very easy to look through that. And a lot of different processes go through that. The hormone, at least hormones do. Well, I would have to say other things do too. If you replace the hormone with the drug, sometimes it's similar.
And also remember industrial chemicals.
Oh yeah.
Agricultural chemicals, paints.
Yeah, they mimic.
All kinds of things can act as hormones.
Yeah, they mimic the thing. They mimic the hormone that would be there. You're right. Absolutely.
So there you go, Snuggles. I think that was worth the price of admission. Okay.
I have other links here because I know that we can do it like next time or whatever you want to do. But I have links because it was another question on your attachment that was about old age and which kind of goes into what we're saying here, but old age as far as the shot and NCOV and things like that. I'm gonna call it NCOV. I'm gonna try to stick to that.
Okay.
But yeah, we can talk about it another time if you want.
Well,
It's up to you.
I want. There's something I want to get to. Just really quickly.
Mm-hmm.
So what my father, someone told me, because he went from I think a baseline of 4 to a 10 or a 12. So so his number went up, and everyone that was his PSA level, 4 nanograms per ml.
Mm-hmm.
So because it was only threefold, someone told me that wasn't a robust enough change to be concerned about.
Okay.
So in other words, you want to see something tenfold higher. Is that accurate? Or is that,
No, I mean,
okay.
Okay. So from the first time he had the test to the second test, how much time had elapsed? A couple months or something,
I
or a
think it was
year?
months. Yeah.
If it was a few months, that's significant. What the heck? That's very significant. If it was like 6 months, that's significant to me because it would make me, like I said earlier about another example, it would make me want to do a biopsy on this patient.
Okay.
He's in his 60s. He has because it's telling me a few things. Number one, if it's increasing, his androgen receptor is working in the wrong way, perhaps. It's telling me also his testosterone level is probably still a little elevated. If he has pain in the area, then that's another indicator that I need to do a biopsy. You don't wait until it gets tenfold, and then you're looking like, oh well, yeah, I got to go to this guy's funeral. Like, what the hell? That nobody does. Nobody does that. Like, you don't wait till it's tenfold. Like, that's crazy. If with any patient of any age or for anything, you don't wait to tenfold is like, no, that's crazy. Fivefold for certain things, if it's benign. But you have to rule out that it's benign first with a biopsy. So a biopsy is a little the best example I can give is where they stick the thing, what is it called? I forget the name of it, but they put that core into a tree.
Okay.
Small needle. You're anesthetized, you're asleep, and they do this procedure where they take a small core out of the prostate, and then they put this onto the little pieces, the little dots. They cut the little pieces of this tube that comes out, the cylinder. They cut the pieces of that, and they put those little circles onto the slide for analysis. They stain the slide for different antibodies, and they determine the Gleason score for this patient. So the dates are very important. Your PSA level at that time is very important. That's what I would do. And I would determine from different markers, not just PSA on the IHC, because you're doing immunohistochemistry. That's what you're doing. You're using an antibody to determine how much expression is in the tissue that you got from the patient. You can do PSA, that's fine. It should be similar somewhat relatively to the PSA levels in the plasma.
Okay.
But then you do other markers, such as neuroendocrine markers. You do markers for specific to prostate. You do markers that are for metabolism of the prostate. Do markers for cell cycle. Like, these are type of markers that you would do analysis for to determine if there is a very high expression. High expression in tissues is determined by darker brown staining. So the darker the brown staining on the tissues, the stronger the expression of that protein is there.
Okay.
The more of that protein is there. So that's how I would do that. And then I would bring the patient back in. I would have my set of slides in a little box. I would put them under the microscope. I would show them, here, this is what we have. Or I would give them the pictures on a PowerPoint, one of the two. And I would show them, these are your tissues from your biopsy. This is your PSA level. This is what we're looking at. These are our options. There's options for you going forward. You went from a 4 to a 12 in 3 months. This is a significant increase. We need to act now and do something.
Okay. That was going to be one of my other questions. What other tools to use besides just the PSA? So it sounds like, if I heard you correctly, a neuroendocrine assay, a metabolism of the prostate,
cell cycle,
because if I hear you correctly, to diagnose this properly, you need multiple lines of evidence.
Yes.
Okay. And as we described earlier, your primary care physician might either not know this, or they might opt to just go with the PSA.
They might just go to PSA because it's like, at this point in time, in history, in the back chat is a article about it's about molecular markers for prostate cancer. So that's exactly. Hold on, I'm gonna try to. I can share.
I'm dropping the link here, guys.
I'll try to share real quick. Where is it? Window. Oh yeah, so it's modern biomarkers. Modern biomarkers in prostate cancer diagnosis. That's the title of the article, and this was published August 7th, 2020. Because some people, if you have something from like 5-10 years ago, they have an issue with that.
Yeah.
Why you got something so old? That's old. Okay. It's from 2020. Okay, dang. Like, I did my best. So the first thing they have is a molecular marker PSA. But it says unnecessary biopsy reduction, not applicable. So they have that. I mean, they have it as number one. You have other things you can use. So they have consideration for initial biopsy. You can consider HK2 PSA, intact PSA, total PSA. So there are different forms of PSA. Total PSA, free PSA, which is floating, intact PSA. And the total PSA is free and intact. You have exosomal RNA. You have these different genes. I've never heard of this one. SPDEF, PCA3, I've heard of that one. ERG, I've heard of that one too. So these are for, these three, for instance, are for improved identification of high-grade prostate cancer. And these are the scoring. They have scoring systems they use for it. PCA3, Tempus ERG. Tempus ERG is like number one. If they don't look at this, Tempus ERG right here, you got a problem. They have to look at Tempus ERG when they do analysis nowadays, pretty much. So it's because it predicts the risk of prostate cancer. And I don't know what PCA is. PCA is prostate cancer. I have no idea what the CS is. But it's supposed to predict the risk of prostate cancer and the potential development or progression of prostate cancer. Non-coding RNAs. Non-coding RNAs. And that's due to previous negative biopsies that you have. They need to look at if you have long non-coding RNAs. HOXC6 and DLX1 mRNA, they can do that. They can do DNA hypermethylation of these genes. So there are a lot of genes. There are other genes such as P21, P53, FOXA1, AKT, PI3 kinase, MAP kinase. There's a lot of different enzymes, enzyme families that they can look at. But this is a good article to help with looking at how they can categorize, the different markers. Neuroendocrine markers are markers that make a hormone-based tissue, like prostate tissue, act like a nerve cell. look like a nerve cell. That's what neuroendocrine markers, what they are. So neuroendocrine markers would be like FOXA1, FOXA2, OCT4, SOX2, SCG3, NGN3, chromogranin A, chromogranin B, aurora kinase A, aurora kinase B. These are all like, it's like a huge long laundry list. I'm just naming the ones I use every day and when I'm, working. These are ones I use, like that I used to look at neuroendocrine differentiation, which is now, Dr. Dunbar, it's not even called neuroendocrine differentiation anymore. It's actually now called lineage plasticity.
Okay.
They don't call it neuroendocrine differentiation anymore. I'm calling it that because that's how you can search for it on Google or NCBI. But now it's called lineage plasticity. Yes, it's the same thing as neuroendocrine differentiation, except that lineage plasticity indicates that as the tumor is transforming and as it's growing out of control, even with treatment, it's becoming more and more plastic. It's becoming more likely to metastasize. That's the only thing. And before neuroendocrine, there was no indication of metastasis.
Okay, so everyone
That's
just briefly,
metastasis, the last thing right there on the right.
Yeah, metastasis. It's breaking out of that tissue that it's in, and it can go to other parts of the body, which is very, very dangerous. Okay.
Yes.
So let's see. So Nikole, I have a question here
Yes,
from Chris. She says, "Hi, Dr. Dunbar. I have questions about this topic. When I'm driving, I'm unsure if it should be posed to you or Nikole. Can you drop both of your emails in the description so I can reach out later?" So Chris, my email address is here.
Put it in there.
Yeah, I show it in the slide in front of all my videos. You can email both of us. Nikole knows way much more about cancer than I do, and I will quickly defer to her. And Nikole has her channel as well. Nikole, if you want to share your email address.
Oh, yeah, I put it there.
There it is, Chris. So there's Nikole.
And also the COVID, if we want to have, or sorry, NCOV talk, we can do that another time if you want.
No. We'll write this out for 2 hours.
Okay.
I was gonna say something else. Oh, guys, this is a very, very valuable game Nikole's giving us. The stuff she just talked about. You might want to listen to this on the playback and listen to it again, because just keep in mind, again, my father, when he got that data back, he slid into a bit of a depression because of his PSA score. But there are multiple variables with that test. And also, as Nikole has described, there are other indicators that need to be considered when thinking about that diagnosis. So, you know what? You get a test back from the doctor, you can feel like your life is over. But anyway, go ahead.
No, I was just going to mention, when you said that clicked in my mind. That actually could have affected his subsequent tests that he had for PSA. Which I'm sure they don't tell us nothing. But when you're depressed like that, first of all, every time you go take it, they're supposed to do some type of like battery of questions for you. Because you want to know if a person is depressed, is that affecting their PSA? Is that a confounding variable to their PSA test? It's not just flat test, So that, I would say either way, whether your father, and I'm sad that he had to deal with that, because that's like, I'd be like, that's medical negligence. Like you're trying to say, oh, this is significant. What? A person of that age where things change that quickly, that's significant. That's significant. Because the thing about a person that age is they have a similar routine. They're not usually traveling as much. They're not really doing as much that a younger person would. Like a younger person, I wouldn't be as worried. I would just do more subsequent tests to see if there's a pattern or something. But with an older person, their routine is pretty much the same every day, right?
Yes.
So that's why I would be concerned. There are a lot of reasons, social reasons, lifestyle reasons why I would be concerned. Because if you're depressed like that, you're going to have issues sleeping, eating, and remembering, like, okay, oh, I forgot to do this, I forgot to do that. Like you'll start having all kinds of effects socially in your life that may not make the PSA look better. It may get worse because of what your response to it was. That's not good. And so that's one thing that goes into, like, what is it called? It's like social care, where they have like people that help patients that are dealing with these readings, because sometimes they just don't tell you, and patients don't know, which is like, I'm looking at them like, oh my God, this is why sometimes people say PhDs are like the real doctors, because the people MDs, they don't care. They don't know what what they're doing sometimes.
Well, in their defense,
like what?
The science is evolving almost monthly.
True.
And part of their challenge is keeping up with everything. If they're a conscientious.
But I don't buy that too. I don't buy that all the time,
Okay.
Dr. Dunbar, for one reason, because I have MD colleagues and friends, and these people be having like 4 patients a day.
Wow.
Throughout the whole day from 8:30 to 5. 4 patients. And I'm like, you didn't have time to read 2 papers? I don't have time to do all that. I had to go to my golf game, and I had to go to lunch at the Four Seasons, and I had to do, XYZ, and I didn't have time for that. I'm like, if we have to read it as scientists, we have to read, multiple papers. I read 3 papers just last night, just, preparing for this.
Yeah.
And just talk to you. And I'm like, if we have to do that, you should be required to do it, because you see human beings every day.
Yes.
I don't see human beings every day. I see their plasma. I'm getting their tissues. I'm getting the effects of these patients that may or may not still be alive. You're seeing a physical person in your office every day. And I think that should be a requirement. More of them they're getting better. The younger physicians are getting better about going to our conferences, coming to our meetings, a lab meeting that we have, to come to the meeting. And it's like, wow, I never thought about it like that. Like, what? You have to know how a patient is feeling. One of them was like, why do I need to know that? How does that help with me giving them care? I said, you have to know if the patient is upset when they come in your office. It's just reading body language. You can tell this patient is upset because they're, you can just tell. I can't really tell. They have a mask on. You can tell by the body. They're like, I can't tell. They got a mask on. You can tell by the body language the person's upset, and they're just like, they're oblivious to that.
That'll affect their stress hormones and
yes. And they're like, oh, I didn't think that would affect it. Oh my God.
Yeah.
I didn't think that would be a problem. I'm like, oh wow.
Okay. Well, just briefly. Okay, we'll squeeze this last question, and then we'll go to the last thing. This one right here from Kalila. Obesity.
Yes.
Wait. Now I will say, and I'm not saying this to put all my family business out there, but just to make everyone aware. I would say Pops did not have the best eating. He does not have the best eating habits in his golden years. So I think that relates to this question. But go ahead, Nikole.
Yeah, I mean, that happens, but also your exposure to different things, because that was in his later years. And we're already noticing that there are certain genetic markers. And so a lot of different ethnic groups are predisposed, we think, to prostate cancer. African-American men more predisposed to prostate cancer than European men. And European men or white men they're more predisposed to prostate cancer than Asian men. Asian men probably the lowest when it comes to prostate cancer incidence. So African men that are in the Caribbean, and Black men in the Caribbean, and African-American men here in America all have the same, very, very similar predisposition or risk for prostate cancer. So yeah, there's a lot of markers, a lot of genes. Most of them are mutations. So there is a genetic component there. It's not all environment. It's a mixture of nature and nurture in a way.
Okay. Thank you, BGS, for your support, both of us. If anyone wants to donate, my information is there. Okay, so Nikole, so everyone, we're going to speak in code a little bit here.
I'll try my best.
the current world event, that's what I call it. The world event, quote unquote, world event. Medication is being prescribed for this world event. I won't say what the medication is. I'll just call it a medication. The principle, and everyone, I've been posting articles on my community tab because I think it's safe to post them there. Certain age groups should not take certain medications, right? Because we talk about this in my day job, because we deal with industrial chemicals, and children are more susceptible to toxicity from this class of chemical than adults are, because they haven't developed certain metabolic enzymes. And so one of the things that we know is that children are not little adults.
Right.
And I think I've heard you talk about this medication for the world event in that context as well.
Yeah.
Right. Children should not take certain medications because, well, what do you have to say about that?
Yeah. So I have, let's see. I'm going to share again.
And we're talking in code here for a reason.
Yeah, I'll try my best. Like I said, I'll try my best.
All right.
I'll talk, but on the screen it says something else.
I think.
So this is an article. Let me go back up to the top. So I can put this in the link in the chat too in a minute. But the title is Evolution of the Immune System in Humans from Infancy to Old Age. And so if you just put in this word, just I'm talking in code as much as I can.
Okay. Yep, we're speaking in code.
Yeah, just put this word in, right here, and search for the word. It'll come up wherever in the paper. That's the best way to do it.
Okay.
So for young children, you have, of course, like anybody, you have innate and adaptive immune systems.
Yes.
And they're starting to mature. They're not mature yet, but they're still at risk for many pathogenic viruses, bacteria, fungus, and parasites. And babies, they were talking about in this previous section to this number 3. So sections 2 and 1 and 2, they talked about, even in utero, how babies are susceptible to a lot of different things. For the most part, in utero, the baby is in a sterile environment, but there can be instances where a child or a developing fetus can be susceptible to certain viruses. Clearly, we know that, with a woman who's pregnant, who's HIV positive, for instance, or a woman who's pregnant who is current world event positive and she's pregnant. Okay. So I'm doing my best. And so, but when the child is born, that is the initial point where the baby is exposed to tons of bacteria, tons of all kinds of pathogens. And so, one way that they try to fight this, of course, good nutrition, hygiene, comprehensive vaccination. These were the main things. So they compared 1900, the UK infant mortality rate was 140 children per 1,000, falling to 7 per 1,000 in 2000, in the year 2000. And so even though that has these things have slowed down infant mortality rate, for instance, still 50 out of 1,000, which is still bad. And so that's one thing when it comes to children. Put it simply, their immune system, the cells that are involved in their immune system, just have not developed properly at that time. They're not developed yet. And if you have any kind of risk factor that could thwart their development, then that's another problem that slows down the process even more. Then I'll just search for this, this word. And if you search for this word, it'll give you more information about from newborn all the way up to a child. And I'm trying to find, where was the other thing? Here it is. So when you talk about older people, I think it was in section 4. Let me go back up to section 4. Yeah. So immune decline with age. And this paper is pretty short. It's 9 pages, so it's pretty short for you to read through. But they say as you get older, as age advances, the immune system undergoes profound remodeling and decline. So the remodeling that occurs in a baby or a young child, that remodeling at old age is basically reversed. So you're building up the immune system as a young baby, young child, and when you're getting older, that remodeling is going down. Like you're declining in the immune efficiency of the immune system. So a lot of people die that are older. A lot of elderly patients, they die from infectious diseases. They say here it's the fourth most common cause of death among elderly in the developed world. And also with the immune system that's not working properly, these age people have inflammation issues. They have other problems: cancer, cardiovascular disease, stroke, Alzheimer's disease, and dementia. And another thing they mentioned that I thought was important was you could have immune senescence, meaning that you have dormancy of the immune system that allows these latent viruses in the immune system to reactivate. That's where you see the shingles and chronic neuralgia, which is basically infection of the nervous system. So this is the time old elderly people, you have this decline of the immune system, and it's just a part of the aging process. So I have that, and I also for this one I think I searched for the word development. Yeah, development. So it's the same article, but I'm just searching for a different word. I'm just searching for the word development, and there was a figure. Here it is. It's the same paper. It's just on a different screen,
Mm-hmm.
and it's just easier for me to organize it. So this is showing a woman developing from a baby all the way through adulthood down to senior citizen level, and at the age of senior citizen. So they have on the y-axis influenza deaths per 1,000 persons, and x-axis is the number of the number in age for years. So they show the dotted line is the pandemic or influenza, how many people are dying from this, and it's going down as the person is developing. So this age children is going up some, but never reaches this point of the young baby.
Wow.
Then you get to women who are pregnant, women who are, adults, middle aged, it's starting to decline even here. And women that are older is slowly after 60, which is also the time between 60 and 70 where you have reduction of a very steep decline of estrogen production. So you have osteoporosis that's affecting them, which also affects the immune cells that are within the bone marrow, um, and the whole bone system.
Yeah.
So those cells are coming from the bone marrow. And if bone
Yes.
marrow is very weak, then your immune system is going to be weak. So it will go up. And then they have seasonal flu, seasonal influenza. So this is from the 1918 pandemic influenza, the numbers. And then seasonal flu has a similar trend, but here with this pandemic, they didn't have that with the seasonal flu. Seasonal flu is still greatly affecting older population and even younger babies too. And this is just looking at females because the next part of the graph still has the same x-axis, but the y-axis is strength of the immune response. And they were saying in here that the immune response, the strength of the immune response is dependent not only on the age, but also on the T helper cell 1, T helper cell 2, the innate immune system, T regulatory cells, and so there's not much estrogen here. Immune response is low. Lots of estrogen here, of course, during pregnancy. So your immune response is very high, and then it drops off when you have less estrogen.
Mm-hmm.
So that's what they said just for women. And I thought that was, that was interesting that they did that.
Okay. So I think what I wanted to get at, and that there could be a whole stream on this, is that children are not little adults. There are certain in my office, in this context, for this particular chemical class, which I won't say, it's a pesticide class.
Mm-hmm.
Children don't have the same metabolic capacity as adults. So even though it starts to develop after 6 years of age, but 6 years and younger, they're more susceptible for toxicity when exposed to this class of chemicals. So, and I think that for this medication that's being recommended for this thing, a concern is children getting that medication too early, because their bodies haven't developed. I mean, I'm talking about their systems haven't developed in such a way that a teen and adults have.
Right. Yeah, I have also. I'm just putting the links in here for you to share in the back chat. To share in the regular chat. They're in the back chat for you.
Okay.
But these are clinical trials. So if people are interested in that as well, they can see. Yes, we do know, like you said, that the children, that their immune system is just not developed. However, they're still going forward with the development of vaccine regimens for children as young as, I think it was like 2 years old or 6 months, something. Hold on. One of them was I think one of them was in 6 months of age. Yeah.
Okay.
6 months of age. So the 3 studies are, number 1 is what is this?
So,
BioNTech Pfizer.
Okay.
BioNTech Pfizer, Moderna.
Just be careful about the words. The words, those names.
Oh, okay. Sorry.
That's
sorry.
Okay.
P, company P, company M, company
Yeah,
S. I'm sorry. I was just reading what was on the screen, what I see. But I just put the clinical trials in the bag because I don't know if we want to talk about that, or we can do it later. I'll try to. I can try to do it on my channel when this little girl will let me. But I'm trying to think of the best way to talk about it, because the details are there on the screen, clinicaltrials.gov, which is what I go to. I don't go to CNN and Fox and all that. I go to the actual trial that tells you what they're doing and how many people they want in their trial, like thousands of people they need. The smallest trial needs over 7,000 people. So that's what I go to look at, to see what they're going to do, because it's eventually going to have to be in school for children. And a lot of the trials are saying they want it to, the estimated completion date is in 2024.
Wow.
When you look at a lot of these trials, not just the one for children, but they have other trials that are used to do post hoc analysis of trials that have already come out. Meaning that they want to do go back and review what they had in those trials and do it again in another trial with giving the vaccine with something else. So some type of concomitant or combination therapy for this event, and that people have. So that's what they want to do. Okay. And if you search a certain way in clinicaltrials.gov, you can find those trials. They're, worldwide.
Okay.
Yeah.
Well, everyone, we will stop it there. So, Nikole, thank you so much for coming through and lending your expertise on actually all your expertises.
Yeah, no problem.
Chris said, again, that she had a question. So everyone, I show my email address at the beginning and the end of all my streams and videos. That's me there. It's a mouthful. Nikole's email is there. Nikole has her own channel as well. So Nikole, do you have anything else you want to say?
No, just thank you for having me on. I'll try to come back and whenever. I'm trying to figure out a schedule for my my own channel, but yeah, thank you so much for having me. I hope everybody has a good weekend.
Okay, yeah, well, I'll have you back again soon. All right, well, everyone, yeah, enjoy the rest of your Friday. Enjoy your weekend, and I hope you got something from this. We said a lot, and Nikole shared a lot of valuable information. So if you have any questions, please leave those in the comment section below and shoot either of us an email. So
Yeah. All right.
With that, yeah, everyone enjoy the rest of your Friday. Please like, share, subscribe. If you're watching this on the playback and you want to donate, that information will be below the playback of this video. And yeah, as always, remember that your attitude determines your altitude. Take care, and we will talk to you the next time. Bye-bye.
Bye.